Very good morning to everyone. Firstly, I would like to thank Professor Phạm Minh Thông for including me into this event. And also I want to thank the organizer for having me into this conference so that I can present my research. It is about the endovascular intervention for acute ischemic stroke in Kentucky University of Medicine and Pharmacy Hospital. As we all know that the stroke have been reported increasing in number, and it is the second leading cause of death worldwide. The current treatment for acute ischemic stroke based on intravenous thrombolysis, which is the RTPA, but because of the complication can happen and the effectiveness is not so high, so some of the patients still were indicated for intervention. We started the interventional neuroradiology for stroke since 2017 to treat the cerebral vascular diseases and to treat the acute ischemic stroke. And then we started the study to review the outcome of our treatment protocol and to audit the successful rate, the complication and clinical recovery of the patient. This is the cross-sectional observative study from early of January 2019 to December 2020, the duration about 24 months. The inclusion criteria would be all of the patient had the acute ischemic stroke, came to the hospital within 8 hours from the onset, and the NIST score is more than 10. The exclusion criteria would be when the patient come to the emergency department more than 8 hours from the onset, or when the patient have the hemorrhagic stroke, patient have unstable vital sign or fatal comorbidity. When the patient arrived to the hospital, we did the clinical assessment first, and then we request for biochemical study, and we do the ECG and proceed with plain and CT angiography. Sometimes we do the MRI in the patient who is cooperative. On CT scan without contrast, we can exclude the bleeding and to detect the early sign of stroke. In the hyperacute state, almost there are no change on the CT scan image. When the patient in the early stage, we can detect some loss of gray-white matter differentiation, or we can see the insular ribbon sign and effacement of the SAR sign. Sometimes we can see the hyperdense MCA sign on the plain CT scan. On this CT scan image, without contrast, we can see the hyperdense MCA on the left side compared to contralateral side. This is the dense MCA sign to represent the presence of blood clot inside the vessel. After that, we proceed straight to CT angiography for better assessment of pathology and to delineate the occlusion site, whether there is large vessel occlusion or not. And also we can detect other lesions. This is the CT angiography image, and we can see the occlusion of the left MCA. Some of the patient was indicated for MRI who have the collaborative or the patient not moving a lot, then we can do MRI. Then on MRI, it is sensitive to detect the small lesion or any lesion at the posterior circulation. and MRI is better than CT scan to detect lesion disease in the early stage. And MRI can assess very well the cerebral artery without contrast. However, the MRI also has some contraindication and very sensitive to motion effect. So we can do MRI in the patient with cooperation. On this MRI sequence, we can see the DWI sequence. We can see the area of hyperintense signal, and on ADC map, we can see the area of hypointense corresponding together, and then this representing the area of infarct. And this is the TOF image, and then we can see the occlusion of the left MCA, and this one done without contrast. When we confirm the occlusion of the large vessel, then we proceed with revascularization. The indication for intervention is the occlusion of the NCA, occlusion of the carotid artery, and occlusion of the basilar artery. And we will do the aspiration first using the penumbra thrombectomy system and the ADAPT technique. Whenever the thrombus already taken out, then we can stop the procedure when we do the run and we see the good flow. If the thrombus cannot be removed, then we can proceed from aspiration to stent retrieval. And all of the stent retrieval, we can use multiple types. We can use Catch-View, Solitaire, Trevo, or another type of stent retriever. After we take out the thrombus, if there is remain stenosis at the site of occlusion, we can proceed with the balloon angioplasty, and we use a gateway for dilation of the stenosis area. And whenever after we do the angioplasty, we wait for 10 to 15 minutes. If the flow is still good, then we stop the procedure. If the area of stenosis recoil, then we put the stent in. The stent we use for intracranial is a wingspan, and the extracranial carotid artery is wall stent. Regarding the result, we have totally 53 patients and the NIST score about 10 to 25. Majority of the patients came late than 4 hours, and about 98% of the patients have comorbidity. This is the table showing our result of the study. And the total successful rate is about 88.6% of revascularization of TC2B above. And there are some patients with unsuccessful procedure due to unable to aspirate the thrombus, because the thrombus can be very large or could be very hard to aspirate. And also whenever the patient have the vessel tortuosity. After we finish the procedure, we follow up the patient about 2 weeks to 2 months. And there are about 31 to over 53 patients, about 58.4% of patients had the significant improvement in clinical symptoms. The complication about 5.6% of subarachnoid hemorrhage, which is related to the procedure. Compared to the other authors and the other report, the successful rate of all of the reports saying that the technical success rate about ranging from 87% to 100%. And the complication is not too high. And there one research saying there are no complication, and the successful rate is 100%, which is very impressive Our study show 88.6% of successful rate, and the recovery rate is about 58.4%, have significant recovery. There are some examples of case studies. The first one, the patient male 53 years old had the right hemiparesis, muscle power is 105, and the GCS is 9, and the patient have global aphasia. This is the angiogram before the thrombectomy. There's an occlusion of the left MCA. And we proceed with the revascularization, and we have the DC3 of the flow. And that patient have good recovery. Another one, patient female, 38 years old, had the right hemiparesis and the muscle power 0/5. GCS8, and the patient have global aphasia. Patient also have the atrial fibrillation. This is the angiogram before the thrombectomy, and there's occlusion of the carotid artery. And after we do the thrombectomy, and we got the DC to be above of the vessel, and then the patient have good recovery. Another one, the patient male 66 years old had the left hemiparesis and GCS9. This is the angio before the procedure, before the thrombectomy, and there's occlusion of the right carotid artery. We proceed with thrombectomy, and the patient have very good revascularization of DC3, and the patient recover very well. In conclusion, with high technical success rate about 88.6%, endovascular intervention for treatment of acute ischemic stroke can save about 58.4% of patients from disability. This reaffirms the role of endovascular intervention as a treatment for acute ischemic stroke due to large vessel occlusion. The satisfying revascularization is a crucial step to salvage the patient and can obtain a better prognosis. This is the end of my presentation. Thank you very much for your attention.